committee room.
Senator, we have Senator Hashmi has to go, but I want to call to order the Health and Human Services Subcommittee. We have 7 bills to consider. We'll have 2 budget briefings after the bills. First will be from the Department of Medical Assistance Services. For those of you who don't know, that's a statewide budget agency or Medicaid agency. Director Cheryl Roberts will be here for that. And then we'll have a second briefing from the Virginia Department of Health. The State Health Commissioner, Karen Shelton, is here. We've got 7 bills. Delegate Salim, you were first, but Delegate Hashmi's got a meeting she's got to get to, so I told her she can go first. So Delegate Hashmi, come on.
I'm a delegate now.
I'm sorry, Senator Hashmi. I apologize.
No need to apologize. Good morning.
Do we have to call roll? No. Okay, Senator Hashmi, your bill is 280, and the reason it's here, I guess, is it's got a Woodrum amendment. It's got a slight cost.
Yes, Mr. Chair, that's correct.
Okay. Well, this is the bill that allows people to get assistance toward the end of their lives with.
I'm happy to present the bill, and yes, the fiscal impact is the Woodrum Amendment that's added on, but medical aid in dying, SB 280, is allowing adults who are diagnosed with a terminal condition and having 6 months or fewer to live, giving them the option to make end-of-life decisions. The bill does require that the patient go through a rigorous request process for the medication. The medication must be a self-administered and controlled substance, and it also eliminates any possibility of the healthcare provider also being a part of actually administering the medication. So because the medication is self-administered, there should be immunity for any healthcare providers, and healthcare providers who choose not to be a part of this have the option to not participate in the end-of-life decisions, but this simply gives an option for the patient and their family.
The way this works is a terminal patient has the ability to make a decision that and a physician can provide them with the medicine, but they administer it themselves.
Yes, Mr. Chair, and the physician can choose not to provide them the medication if they don't want to participate. So it would be a healthcare team that actually wants to be a part of the end-of-life decision.
Okay, does anybody have any questions for Senator Hashmi? Senator Evans got questions.
Yeah, thank you, Mr. Chairman. I would ask Senator Hashmi, do we know how many other states have similar laws currently in effect?
I believe there's 10, including Washington, D.C.
Thank you. Thank you, Mr. Chairman.
Okay, the Woodrum impact is due to a new felony that's being added in this bill, and that's for one who goes too far, I guess.
Mr. Chair, it is, I think, just a safety rail in case someone should face any coercive actions. But the safeguards that we have built into the legislation really prevents coercion, prevents abuse of suffering patients, and puts all the decision-making in the hands of the patient themselves.
Okay, are there any other questions for Senator Hashmi?
Mr. Chair.
Senator Favola was first, then Senator Boysko.
I move that we report the bill.
Okay, Senator Boysko, do you have a question?
I had just a comment, and I will second that. I just wanted to make everybody aware that our former colleagues, Congresswoman Jennifer Wexton, sent a letter that she wrote in support of this letter. As a former colleague, I think it's worthy to note that. But I second the motion.
Okay, well, the bill had a public hearing, I guess, in Education and Health Subcommittee. Okay, well, so it doesn't need a public hearing here. We've had a motion to recommend reporting. All in favor, say aye. Aye. Opposed? Okay, we've got 1 no. The bill is recommended for reporting. Thank you.
Thank you, Mr. Chair.
Okay, Senator Salim was next, and you've got Bill 312, is that correct?
That is correct, Mr. Chairman.
Thank you, Mr. Chairman. 312 is specifically to, in 2018, the General Assembly adopted House Resolution 118 requesting that the Department of Social Services study the regulation of independent living communities. And in that study, they did define what independent living communities were. And what SB 312, what it does is it incorporates that definition and then puts, rather than doing an independent ombudsman, we are requesting that the independent living communities be not regulated, but with the oversight be under the long-term care ombudsman that's already created. So what this bill does is it adds the definition of independent living, which means any congregating housing reserved for residents ages 55 and older who do not require assistance with activities of daily living from community staff member that provides 2 or more services such as meal, transportation, laundry, or housekeeping for their residents. Independent living communities include such services for which a resident or representative acting on someone's behalf contacts through third party provides and communicates the overseas residents either through daily check-ins or emergency call system monitored by the community staff. So
Mr. Chair, I move that we adopt the amendment in the nature of a substitute.
Adopt the substitute. Okay, got a motion to adopt
Thank
the
you.
substitute in a second. Is there all in favor, say aye.
Aye.
Okay. The amendment's properly before us. I was, when I was looking at this bill yesterday, I was wondering, independent living community for, like Westminster Canterbury has a tiered sort of care. At the top tier, or I guess there's the independent living tier, and that would be subject to this?
That is correct, as long as it meets the definition. In the past, we have not defined what independent living communities are. So what this specific amendment does, it not only defines it, but it also puts it under the long-term care ombudsman that's already there. So we're updating an existing ombudsman rather than creating a separate one.
Okay. This bill has a fiscal impact of over $1 million the first year for 7 full-time employees and $1 million the second year. Also,
Correct. If I could refer to the council or the finance folks here, I think the original fiscal impact that's included on here was the $1.1 million if there was a separate ombudsman. So since this is adding on to an existing ombudsman, I think there may have been a new fiscal impact.
Would Mike, does the substitute change fiscal impact?
Mr. Chairman, so of course at this point we don't have a new fiscal impact statement because it's just before you now. It may reduce it slightly. I think you're adding to the responsibilities of an existing office. The current office of the long-term care ombudsman isn't really fully funded as it's supposed to be anyway for its current duties. So you would still need the staff to be able to respond to the complaints and conduct the investigation. So I think the fiscal impact would still be substantial.
Mr. Chairman,
Senator Favola.
I do think at some point this is a good idea, but I think the fiscal impact is too much for us to absorb at this point, especially if we're talking about independent living where health care services are not provided to these individuals. We're talking about maybe transportation or housekeeping, so it's not a direct impact on their health and safety. Could be, but not as direct as a healthcare provider. So given that, I think I would move that we not carry it over, perhaps. That would be my motion.
Let the subcommittee take a look at it in the interim.
I think so. I think it needs just a little bit more work, with all respect to the patron.
Well, Senator Reeves, is there one, we want a second on that motion?
I'll second, Senator Bull. My bigger concern is we're asking for 7 folks, but Senator, are there that many complaints that we have to set up a whole sort of new division to handle all the complaints of long-term care? And Mr. Chairman, Senator Salim, if we do, then we got a bigger problem than just trying to backfill it with personnel. We need to look at, see why we're having so many complaints.
Mr. Chairman and Senator Reeves, The study showcased that they are leaving a specific community or specific group off of the regulation part, and that's what the study came up with in 2019, and they did recommend a separate ombudsman, but after looking through different groups, after looking through what we currently have, with the fiscal impact and with the way the current terms are set up, it made sense to include it with the long-term care ombudsman, and not only updating the definition of what additional care or additional oversight they have, but also putting it under them. So there is a need for it. As Senator Favola has mentioned, it is they don't provide security. They don't provide anything that has to do with someone's physical health, and that's why it's a separate community that gets left out. So I take Senator Favola's recommendation. That is correct. Thank you, Mr. Chairman.
Yeah, just to speak to it, I'm going to support the motion, but I just wanted to make Senator Salim aware. I had heard from Leading Edge Virginia, they were concerned with the way the legislation was constructed, that an ombudsman office without any level of regulation would be reduced to a mere complaint unit without definitive guidelines or resolutions, and would not meet the objective of the proposed resolution. So you may want to get with that group as we look at this in the interim, just to see if you bring this back next year, if there's further detail that would flesh it out and make some of the stakeholders more on board.
Mr. Chairman and Senator Eben, thank you. We will take that into consideration.
Motion is to carry over. It's been properly seconded. All in favor of that motion, say aye. Aye. Any opposed? Okay, the bill will be carried over for the interim.
Thank you, Mr.
Thank you,
Chairman.
sir. Okay, Delegate Rome, or Senator Rome was next. I apologize.
There's a way to make amends for that. Mr. Chair and members of the subcommittee here, SB 291 would direct the Department of Aging and Rehabilitative Services to develop a training program for court-appointed guardians who are not a part of the public guardianship program on their duties, responsibilities, and other relevant associated topics. The passage of this bill would implement recommendations 18, 19, and 21 from the October 19th, 2021 JLARC report on Virginia's adult guardianship and conservator system. So, Mr. Chairman, based on estimates from DARS, the program would require $228,083 to be appropriated in the first year in fiscal year 25, and $160,864 thereafter for the continued maintenance and staffing of the program. The bill does not direct DARS on how to develop the training program, instead giving them the latitude to create the program as they see fit. And finally, in coordination with the Virginia State Bar, DARS will ensure that their training will conform to VSB's standards for their continued legal education program. This will provide those guardians that are practicing attorneys to use this training as credit toward their yearly CLE requirements.
Okay, this would kick in when, say I've got an elderly family member and I file suit to have a guardianship set up, or would it kick in other cases as well?
So, Mr. Chairman, this would be if you have an incapacitated adult and you have a court-appointed guardian. At this point, that guardian who is now court-appointed will need to be trained, and we have developed this entire thing, based on the JLARC recommendation with it, based on everything that's come with it, to make sure that we have a uniform standard for this, because right now the public guardians are trained. And what we have is what JLARC found was so many levels of inconsistencies for private guardians, where just to be blunt and honest about it, in 2017, when I was still delegate-elect, one of my constituents died because of what I would consider intentionally malicious lack of guardianship, where one of the attorneys told me on the phone that the reason they took her off of food and water was to, quote, expedite the inevitable, end of quote, over her sister's wishes. And so I promised her back then that I would do everything in my power as long as I'm here to reform the system. And this is a pretty big part of that, Mr. Chairman.
Are there questions for Senator Rome?
I will second that, and I will just say that several groups have come to me concerned about the lack of training and actually the need to ensure that the guardians understand their fiscal responsibilities and their obligation to adequately manage the finances and personal decisions of the person they're in charge of. So it's an important piece in our whole safety net, and sometimes it gets overlooked. So
I agree with that, but let me ask you, Senator Rome, have you got budget amendments in for this?
Yeah, yes, Mr. Chairman.
and Mr. Chairman,
Got a motion, was it seconded?
I did second. I have one other question.
Okay, Senator Favola's got a question.
And this is for staff, maybe Mr. Tweedy can help me. As I understand it, once the curriculum is developed, there's a lot of upfront costs, but in fiscal year 26, the cost goes down, and then I understand that 30,000 in general funds would be needed to maintain that for every year thereafter. So I don't see this. I don't want to say 30,000 is insignificant, but in our world it is. I don't see a significant cost in the out years after we fund this upfront.
This calls for the development of the training module, and it's not really going to be effective until July 1 of next year. Is that correct?
That's
Mr.
what it
Chairman, that
says.
is correct. July 1, 2025 is when that would take place.
But the ongoing costs are significantly less.
Yeah. Well, it could, I guess it could be online training. Is that?
I mean, I believe I would defer to DARS on that, but I mean, obviously we'd have the preference for in-person on that, but again, this is, like what I was saying before, this is going to give DARS the ability to have the latitude to be able to develop that training as they see fit, and so that if they need to adjust or be flexible or learn things year over year, change things up a little bit, then they'll be in the best position to do that. So
DARS is
I'll
not an
defer.
agency with a whole lot of money. Okay.
Good morning, Catherine Harrison from DARS, and we are anticipating that it probably will be like an online module, understanding that it will probably need to be updated in the out years, and we're also considering that we'll probably have to have two different types of modules, those for attorneys who are looking for continuing education, and those more focused to, for example, a parent who's a guardian or a child of a parent who's a guardian. The outlook is probably a little bit different for those.
And I guess with the online, it's like some of the online training we as legislators take. You have to, there are certain checkpoints you have to, to make sure you're paying attention. With online CLE, it's the same thing. They give you codes you've got to know at the end of the.
And Mr. Chairman,
So we have my CLE done.
every legislator, for example, is required to take sexual harassment training,
Right.
for example. And so, and the way that they set it up, it's 45 minutes, and it's just like, and your sound will be on as you're doing this, right? There's definitely ways, as you were just saying, to ensure the integrity of that.
Senator Obenshain.
I think this is a good thing. But right now, are guardians, is there a central database of who's been appointed guardian in Wise County and Rockingham County? Is there?
Catherine Harrison from DARS again. OES might be able to better answer that question. Guardians are required to file an annual report with the local Department of Social Services. So the local departments know who should be sending in their reports in their localities. And if folks don't send in their annual report within a certain amount of time, they do report that to the court.
So, Mr. Chairman, I guess my question is related to, how are you going to enforce this on a statewide basis? Is there going to be a database in which you are, having to annually certify to DARS that you're doing this? And how will DARS know that, I've been appointed as guardian in Rockingham County or Page County, and whether or not I've complied?
So there will be a change to the annual guardianship form. It's also included in this bill where when the guardian submits their annual report, they'll have to fill out that they've completed the training. And I think probably internally, we'll have to work out some sort of mechanism where there's something tracking that as well. And my understanding is that upon certification, that documentation is supposed to be sent to the local Department of Social Services that a guardian has been appointed, and that's the current process.
The guardian not only is to report to the Department of Social Services on an annual basis, but if they're appointed conservator, they have to file with the Commissioner of Accounts every
That's
year as
correct.
well.
That's correct.
And Mr. Chair, I'll note that Tracy from JLR is here. I think you had something you wanted to mention.
Thank you, Delegate Rim, Senator Rim. Mr. Chairman, members of the committee, I just wanted to agree with everything that Catherine explained. That is a very detailed explanation of the process. Yes, there are modifications that are being made or have been made to the guardianship form that each guardian has to complete and submit to DSS, to their local DSS, and in that they would indicate that they have taken the training.
So, Mr. Chairman, so then it would be up to the local DSS to report to DARS that we got a bad one out here. It didn't complete the training.
Mr. Chairman, Senator Edmund, yes, it
Okay.
does fall in DSS, yes.
I've got to feel I'm sorry, Senator Boysko.
Mr. Chair, I was just going to renew my motion to.
Well, the
recommend
motion
it.
was pending. We were trying to get as much information as we could about how this would work. And nothing else needs to be said?
Just for a point of clarification, I think it would be if the training hadn't occurred, it would probably be reported to the court.
Okay.
Because
Okay, we've got a motion and it's been seconded, all in to report. Now, we're not doing causes this year, so if we report something, we got to pay for it. Okay? Got it. Okay, so we've got a motion to report that's been properly seconded. All in favor, say aye.
Aye. Opposed?
Okay, the bill reports.
Thank you, Mr. Chairman.
Thank you, Senator. Okay, Senator Pillion.
Good morning. Draw your attention to Senate Bill 620. Mr. Chairman, this makes modifications to the long-term services and support, which are screenings required by Medicaid when individuals request enrollment in the Program for All-Inclusive Care, most commonly known as PACE. This legislation will enable the screenings to be performed by the PACE assessment teams, which have qualified reviewers already in place. This will enable the assessments to be completed on a timely basis so individuals can get the appropriate level of care that they need. There's currently a delay about 70 days. The fifth on this, while the legislation could impact Medicaid long-term services and support costs, an exact estimate cannot be determined at this time. However, DMAS does not expect any fiscal impact to be significant.
Okay, Senator Evans got some.
I was just going to note that it had no fiscal impact, as the patron said, and make a motion to report.
I will second that motion.
I've got a motion and a second. Are there any other questions for Senator Pillion? Okay, all in favor, say aye. Aye. Any opposed? Okay, that bill reports.
Thank you.
Okay, do we have Senator McPike out there? If not, Senator Favola's got a couple of bills.
Yes.
Senate Bill 177 and 179.
Thank you, Mr. Chairman. So Senate Bill 177, as you recall, it is a recommendation from the Behavioral Health Commission, and it was also a recommendation from JLARC. It directs the Department of Human Resources Management to come up with a policy so our nursing staff and our psychiatric technicians who are working in our state hospitals can work a 12-hour shift. This is not an amendment to extend their hours or change their status, but to merely allow them to work a 12-hour shift, because that's a very desirable opportunity that the nursing staff and technicians would like. It's a retention tool, and it could possibly be a recruitment tool.
That was the idea. We don't have enough workforce. The issue that we came up with was that figuring out how to get to 40 hours, paying for people 40 hours to paying for 36. And what we thought we might do is put a delay enactment for a year on this and require the a report back, the Department of Behavioral Health report back to the money committees on December 1 of next year, so we make sure we know how to implement this.
Yes, and I think that that's probably a good approach. And We worked with the Human Resources Department, so there should be peace in the valley, and I really think this is worthy of passage.
Okay, well then, do I have an amendment proposed to delay enactment on this? Okay. Okay,
Second.
and then a report back to the money committees on December 1 of this year, so we know how this is gonna, we know this is gonna be smooth, but because I agree, it can be a recruitment tool, and also a retention tool. The amendment's been proposed, all in favor, say aye.
Aye.
Okay,
Second.
okay, motion to report and seconded, all in favor, say aye.
Aye.
Okay, the bill reports.
Okay.
Senate Bill 179.
Okay. Senate Bill 179 was also a recommendation of the Behavioral Health Commission and JLARC. I turned it into a pilot so we could actually get some information. It's a pilot in 3 hospitals, and what this pilot does is it would direct 3 psychiatric hospitals to take charge of the discharge planning for patients who are admitted for 30 days or less. And then a report would be required to come back to the respective committees, including the money committees, and I forgot the date. I think the date was November 1st, 2025. So I think this is very worthwhile. It's an attempt to try to ensure that what the community services boards do and what our psychiatric hospitals do are a little bit more aligned, and that we can actually allocate responsibilities in a way that makes more sense. I worked with GBHDS. I think this is very worthy of adoption.
Okay, the amendments were made in education, health, they don't need to be
Yes.
made here.
That's correct.
Okay, are there any questions for Senator Favola? Is there a motion?
Move to reform.
Second.
Okay, all in favor of reporting the bill, say aye.
Aye.
Okay, that bill is recommended for reporting. Oh, Senator McPike is going to be here or not? Do we know? Okay, well, why don't we take up the budget reports, and then we'll, if McPike gets here, we'll do his bill. If he doesn't get here, we'll do his bill. Okay? You have to go to committee, okay.
Where's not till 8:30? Remember, we got it changed.
Okay, so Ms. Roberts, if you want to come up and tell us about DMAS, that'd be great.
Good morning. Excuse me? Yes.
Lien processing.
Michael, I do not see it moving.
Processing liens.
Oh. That'd be a good question. Yes, ma'am.
Yep, we're trying to get the presentation up. Good morning.
Good morning.
Oh, good. Hi, good morning. I'm Cheryl Roberts, and I'm the director for DMAS for Medicaid. And I'm here, I'm going to say that with our Chief Deputy, Jeff Lenardi, and the CFO, Chris Gordon, in case you have any questions I can't answer. What I'm going to do is 3 pieces. I'm going to go through a quick overview of Medicaid just for you to have where we are. And then I'm going to speak to our biggest initiative, which is the procurement, and then talk about the governor's initiative. This is our mission. Our mission has changed a little bit over the years in that we're talking about giving quality health care both for coverage as well as services. When I talk about who covers, we cover about 2 million people. And if you notice, children is number really high on our list in terms of coverage. Most people don't see that. The Medicaid expansion plays a big role in the adults. And one of the things we do that's unique to Medicaid is taking care of the aged, blind, and disabled, as well as people in nursing homes. The biggest thing I like people to know very quickly is always to remember is that DMAS can't work autonomously, that all of our authority and our funding comes either from the federal government or you. And so we always talk about this. So the General Assembly plays a big role in the way we actually function. We spend about $23 billion a year. I like to talk about the 3 levers quickly about how that money is being generated. One is on enrollment, whether the enrollment goes up, down, and case mix makes a difference. The second is on rates, whether rates and services go up. And the third, obviously, is utilization. We have two delivery systems. Most people know about one, but we have two. One is the fee-for-service delivery system that we pay, and we're actually the payer. And the other one is our biggest one. It's 96% of our business, which is managed care. We actually do contracts with managed care. We pay them a capitation rate, and they do services that are Medicaid services as well as additional enhanced services. We used to have two programs, the Medallion program, which most of you heard of, and the CCC Plus program. We spent the last couple of years combining them, and we call it Cardinal Care. And now you see the little bird on everything that we're doing as we push the Cardinal push through. The thing that we're doing now is that after we have put those two together is to reprocure. We have not reprocured since 2016, 2017. I mentioned that only because that was where iPhone 4 was. There was no TikTok. So we have some things that we have to do in order to make us to look like and be one of the best in the country. So we're working on that. While we're in the middle of a procurement, we have to mention legally I'm in a blackout period, so I cannot give you any details about how the procurement is going. But what I did want to tell you is because it's such a big transformation, at least some of the reasons we're doing it and what we hope to get out of it. The first big thing that we'll hope to get out of it, obviously, is the Right Help Right Now program, the behavioral health. And what you're going to see in these 10 goals, a lot of these issues are lined up with some of the governor's initiatives, what you're going to see when we do the governor's bills. So first one is behavioral health. Obviously, that's a big focus. We've been working on crises, prevention, and recovery. And children, obviously, is going to play a role. We'll talk about that as we go to the next level. Maternal and child health outcomes, we've been working very seriously on that. In fact, lots of lessons learned as we've been working in Petersburg. I could talk endlessly about some of those, but I would just say that working with members directly, as we've been doing both in maternal and child health, is helping us as we look forward to handling some of the geographic as well as the ethnic disparities. One of the things that we talked to provider groups about was making sure that we were streamlining the process, and that means including training and monitoring, because the idea is that without the providers, we would not obviously have a program that's strong. The big one is foster care. As you all know that we have a big focus on foster care. We cover the 5,000 kids. We had them under all 5 plans. One of this does is bring them to one. And that's big because right then, as I say to people, is that when you're pulling a child out of their home, that's not the time to ask which insurance company you have, right? You want one plan who's able to handle that 24/7. This procurement allows us to do that. The other one is long-term care. I had the joy of this week of obviously meeting people who are waiting for a waiver list priority list and also people who are in nursing homes. And one of the things we're spending a lot of energy on is making sure that that group, whether they're in the community or they're in a nursing home, get quality care. Last but not least, obviously, we're looking at the way we monitor things. So this work is not just on the health plans. It means that the department is also working very, very hard to make sure that, because you can't have a program that you change if you don't change too. So we're doing things internally about monitoring and data and oversight to be ready for this program. We started this process in October of 22. The procurement went out in August. The bids came in October. Our goal is to announce sometime before the spring of 2024. And I smile because when I used to say winter, everybody thought it was October, November of 24. And then starting regional rollouts. We'll start with Tidewater, then Central, take a break, then do Northern Virginia and the Southwest. Any questions? Good. Let's talk about the budget. And as I mentioned, remember the 3 levers? So we're going to talk about them in levers. So first, services and supports. The number one thing that the governor is focused on is the developmental waiver slots. That is for the priority 1. We believe that that is very good. It's, again, I've met too many people who are on priority 1 waiting lists, and so we're hoping that this will go. The second one is...
Ms. Roberts, you recognize that the waiver list is not going to be met because of that. It's added to every day, right?
I know there's no end point. Yes.
And the budget does not include an increase in pay for people that do the work. Is that correct?
Yes. Yes, Chris is accurate.
Okay, thank you.
Yes. The second one is obviously the one that we're looking at that goes with Right Help Right Now. And that one is that we're looking at to take some of the services that we've had since 1999 and actually make them evidence-based. The first one we're going to work on is the one for school services, which is TDT. And so we'll be working on that to make them evidence-based and more current so that they actually can help people that we're looking for, our most vulnerable kids too. The next one is to look at waiver limits, which is basically we had caps in different places. This allows us some more flexibility. The other ones are things we learned from the pandemic. One of the things we learned in the pandemic is how well telehealth works. And so you see the support here that we're looking at, including telehealth for the developmental waivers, for peer, and also for peer recovery. We're trying to, because we're being efficient, is trying to move away from contractual staff when we can and get permanent staff, which is good to have. So that's one of the things you'll see here. And then we're looking to make sure that people who have alternate coverage, that we identify them. That makes our capitation rate less, and so we're looking at its efficiency. We have a system, and I'm sure you heard this from DSS2, that was made in the 80s. And so we're looking now, we have to, actually CMS has said that they will not allow us to continue unless we upgrade it. And this is the part of the process that we're working to upgrade that system. That's the system that every claim, by the way, an encounter goes through. So it's really core to our business. Weight loss drugs came in big and heavy. My hero, Oprah, is pushing these weight loss drugs too. However, one of the things we noticed here is that we're trying to tighten up the criteria. It does not affect people who have diabetes, or it does not affect people who have this change. But what it's doing is for people who may be able to do alternatives, is that we're tightening up those criteria a little bit. So we've been working on that. I shouldn't say a little bit, but we're tightening up the criteria. Obviously, the next one is the procurement. Part of this, by the way, part of this expense is mailings and things like that we have to do to actually bring the system and bring the program together. We were able to get preventive services, which we're very happy about, but believe it or not, because of a little technical change, which we had, which is that we were not actually stating that you had to use the United States preventative treatment, we were not able to get an enhanced benefit. So that's what we did. We actually changed that, and therefore we'll get additional money from the federal government because of that. And then the last two are basically changes that we're doing mostly on the technical side. One in the funding to support GME residencies, that's an increase there to have more. And the other one, in terms of appropriation for facilities, that's a decrease based on what we're seeing in trends. And improving third-party liabilities, again, I mentioned that we're having that kind of, you have a question? I'm sorry.
I do. I was waiting for you to get to that. Can you tell us a little bit about the status of your third-party liability efforts? For those on the committee who are not lawyers, I will tell you that that this is the subject of a lot of discussion among lawyers. Somebody who's representing an injured person, we've got a lien that has to be satisfied to DMAS. And we're trying to give DMAS, those lawyers are trying to give DMAS money because we owe it. And our clients owe it. And when dealing with CMS, literally lawyers get those lien computations within days, if not a week. Sometimes now to get it from DMAS, it takes a year or longer for us to, and frankly, most lawyers can tell you within a few cents right away how much the lien is going to be because we have all the medical bills. So, where are you all, and what's the holdup in trying to process this incredible backlog?
We acknowledge that we have a backlog, and I'm going to let Chris talk more about what we're doing with the liens.
Mr. Chairman, Senator Overshain, thank you for the question. Ever since the passage of Medicaid expansion on January 1st of 2019, we've had pretty much exponential growth in the number of people that have joined Medicaid. You would be surprised at the number of folks that actually get into car accidents, the one that you're talking about, where there is a TPL lien. We call them casualty recoveries, as you know. We approximately have 14,000 under roof right now. 8,000 of those are currently at the Office of the Attorney General. 6,000 of them are at DMAS. We have a team of 14 staff, 6 full-time, 7 contractors, and 1 wage to actually process those. Processing and working with the legal representation when those folks come up involves several things: getting a letter of representation from the lawyer, a HIPAA compliance, as well as an amount of what they think it is. Those 3 things do not often come in sync, and we have to go back and forth with the team at the lawyer's office to actually get the HIPAA. We also get duplicate complaints every single week. One of the things that we've done in order to reduce the backlog is to ask basically for those folks at the Office of the Attorney General where they're doing the investigations, and they're actually helping DMAS because the agency doesn't have the authority to settle any claims above $3,000. So if there is representation, those get punted over to the OAG, and they take a cut of the amount of what the settlement is. And so what we've done and what to try and reduce that is, instead of verifying and checking that information from the OAG, we basically authorize them to go ahead and just send out the lien letter. So yes, you're accurate. In the past, it has taken a year. We've taken steps to reduce that. The biggest problem, as you noted, is understanding the entire medical bill and all of the follow-ups that are related to that incident. So I think you're 100% accurate. That once you get that information, the settlement amount information, we can gather that, provided we have those 3 antecedents, the HIPAA declaration, as well as the letter of representation and the lien amount.
When I monopolize this, and I talk to you a little offline, but my question is, I would ask, with the technology upgrade that you talked about, can we expect that that DMAS will be more in line with CMS in terms of speed in processing these liens and, getting the money that is owed to the state?
Mr. Chairman, Senator Obenstein, that's accurate. Director Roberts, under her approval, has authorized DMAS to move forward. We're using some of the revenue recoveries that we get from TPL liability. It's our fund 02207, Mr. Tweedy knows that, fund account to actually fund. So no general funds are used to support the state share of that to draw down federal match. It's going to cost a little over $1 million to develop an online portal so that lawyers like yourself can submit those letters of representation, HIPAA forms, as well as interface with it very quickly.
CMS.
Like CMS. And so we will be able to process that more timely. And when there is TPL members that actually receive or actually obtain legal representation, if they're not seeking a settlement, we will be able to do that extremely quickly. And so Director Roberts, under her leadership, we've taken steps to address that.
Thank you. Thank you.
So yes, we do acknowledge it's a problem, and we are trying to fix it. We do acknowledge it. The last are all mostly technical things. Aligning the outpatient standards, removing supplemental payment language, and then obviously implementing a supplemental dish pool. The last page is, already, that is how we handle our finances. It just tells you, basically, you can tell that obviously we have increases and decreases based on utilization, and then what we expect in terms of, we're looking at patterns. And again, I had brought up, you're looking at patterns in terms of utilization, inflation, rates, and enrollment. Any questions?
Questions for Director Roberts. This is going to be one of the drivers of our budget this year. In the unwinding process, 250,000 people have come off your rolls, but the net is only 90,000 because you are adding 20,000 people every. And as we talked the other day, you think that the majority of those people are from the Medicaid expansion population?
Yes, what we did was our initial look at it at this point is that the people we're seeing is children and expansion people. Mm-hmm.
Any additional questions? Okay. Senator Boyce goes first, then Senator Favola.
Thank you, Mr. Chair. So let's go back to the adding developmental disability waiver slots.
Yes.
I believe Mr. Chairman brought up the fact that we don't have enough providers for to handle all that. So what is I have a budget amendment, but what is the capacity load that you're looking at, and how much do you expect that would cost additionally that is not accounted for in our budget?
I don't have that information offhand. I can get that for you. My counterpart has that, Commissioner Nelson. But I can tell you that we're working hard now to have a plan to help get providers, because we know that we have to get to that capacity. So the question is not ignored. The whole administration is working on that.
Thank you. Mr. Chair, just follow-up question.
Senator Boyce.
Because we hear from our constituents every single week about their concerns of their loved ones who do not have the waiver, and these are elderly parents who are, worrying about their kids.
Yes, I met them too.
And so I think it's really difficult for them to have hope that we're gonna end the disability waivers slot shortfall, but then they get their waiver and then they don't have the services because the services don't exist, and there are not enough professionals to provide the services that are necessary. I think it's really important that we are clear about that and that we communicate that with the families who are counting on this, because it's a very difficult, situation.
Yes, and again, my counterpart could probably talk more about it, but the commitment is there on both sides to do everything we can to streamline it and make it easier for providers to get in. And yes, we are telling members and telling them is that we know we have to work. Remember, I was talking about the same with procurement. We have to be ready on that side too. So we are very clear that that's the challenge, but also we believe that getting the waiver slot is the beginning of that challenge, of relieving it. Mm-hmm.
Okay, Senator Favola has something.
One of the topics that keeps coming up, and there is a budget amendment before us, I think actually Senator Eben, you may have put this in as well. The SSDI, it's a federal disability program, as you're well aware, and there is a federal law that Medicaid recipients actually have to accept the SSDI if in fact they're eligible, if the federal payment is eligible, if they're eligible for the federal payment. I have a constituent, and I've had this constituent for a number of years, who wants the SSDI payment disallowed, not counted against the income bracket. The individuals I have spoken with at DMAS believe that if we were to go down the path and ask for a waiver to disallow the SSDI income, we would have to apply it to all of the Medicaid recipients, and it could have quite a budget impact. My constituent is getting different information. Could you respond to that?
I'm not the expert, but I can actually meet with you and actually get the experts to talk to you. Okay, so Senator, I don't have that as the expertise, but I can get the expertise to you.
And I appreciate that.
Senator Eben has a question.
Yeah, just to say I'd love that information too about legislation on that topic, so we'd love to.
Can definitely do that. So Jeff, we'll meet with them quickly. We'll make sure that happens. And thank you.
Okay, and now we're going to hear from Dr. Karen Shelton, who's Commissioner of the Department of Health. Dr. Shelton.
Good morning. Okay. Very good. Well, good morning, Mr. Chairman and members of the subcommittee. I am Dr. Karen Shelton, the State Health Commissioner, and I'm here to present the provisions of the governor's budget pertaining to the Virginia Department of Health. Our mission is to protect the health and protect the well-being of all people in Virginia, and we do that with great energy and a wonderful team that goes forward with many different scopes of practice. We have 11 different programmatic offices as well as 6 administrative offices that help to administer our subject matter expertise. Then we have 35 local health districts across the state with 119 local health departments that help to administer services. These range from everything from making sure that you have clean drinking water, proper sanitation, safe restaurants,
also looking at shellfish industry, as well as beach monitoring, and a scope of services including epidemiology, working with community resources. Our Office of Health Equity also includes our Office of Rural Health, along with our Workforce Development Program, in addition to the things they do to help us focus on equity of health across the Commonwealth. We also deal with licensure for hospitals as well as long-term care facilities, and other things including vital records, where you get your birth and death certificates. Our agency's strategic goals align with our priorities to focus both internally and externally. Internally, we want to make sure that we have a valued workforce that is competent to carry out our tasks at hand. As you know, many of our people have been greatly affected by COVID over the years, and our agency had a large effect along with other healthcare agencies regarding COVID. So as we look to build and retain our teams, we focus on our valued healthcare workforce. We're especially grateful for the ARPA funds that have allowed us to bring our technology more up to date. This was very vital as we look at installing electronic health records throughout the state, as well as the technology to help us with our financial management systems. We also want to make sure that we're a trusted source of public health information to our public as we foster healthy, connected communities. Our community health assessments are vital as we work with our community resources and hospitals and others to assess the healthcare gaps in a community and how we can best fill those. We look forward to creating health opportunities within the communities that people can achieve their best health. As we look at our funding, we look at the fact that we do have approximately 21% of our funding comes from general funds. Approximately 18% comes from special revenue and other dedicated funds, which includes local matches from our localities, along with revenue that we generate, along with other special pass-through funds, such as from the DMV for the Office of EMS. Our federal funding, that is COVID funding, has been great over the last few years and is beginning to come back down a little bit there. And it represents approximately 21% of our funding. And then our federal funding, which is non-COVID, approximately 40% of our funding, has some of our larger grants, such as WIC, which is our Women, Infant, and Children Nutrition Programs, as well as our Drinking Water State Revolving Funds to help provide drinking water infrastructure across the Commonwealth. Specifically on our budget requests, our budget requests for this coming year include our base appropriation with the central appropriations, which would include things like VITA, healthcare, and other salary increases. And then our new funding appropriation per the governor's budget is $18.8 million for a total non-general fund budget of $287 million and a total budget for the agency at $1.1 billion. This is just a little bit of a kind of show you relatively the amount of our fundings, where the blue is our general funds, which have gone up in the past few years. Our special revenues have gone up more slowly, and then our federal funds took a particular large jump this in 23 when we received additional funding for Office of Drinking Water from the Bipartisan Infrastructure Law. So we're very thankful to have those monies from the federal government. This is showing, along with our COVID monies, the difference in our agency. So we were approximately a $900 million agency before COVID and went up almost double that, approximately $1.6 to $1.8 billion throughout COVID, and back down, settling about $1.1 billion at this time. As we look at our budget amendments going forward for this year, we wanted to focus specifically on the Office of Emergency Medical Services. This is the office that supports the work of EMS agencies across the state to provide the best pre-hospital care for our people of Virginia. And so this office has had its struggles, as we've discovered this year, with an overspend. So in order to understand the overspend, it's important to understand a little bit how we get the budget for this office. This office is funded entirely through the Department of Medical Motor Vehicles and the 4 for Life program. You may be familiar with that. It originally started at 4 for Life. It's actually now $6.25 for life. And the funding for the Office of EMS is very prescriptive in the code as to exactly how these monies should, when they come in, should be spent. And so 30% goes to operations, 10% administration, 26% is a return to locality. So when you register your vehicle in your locality, the 26% of that goes back to that locality for emergency services.
Dr. Shelton, this is that $33 million problem we read about a couple weeks ago?
Yes, sir.
Okay.
And so the 2% goes to the volunteer rescue squads, and the 32% is the Rescue Squad Assistance Fund, and this helps to fund the special funding for the EMS agencies for things like ambulances and other medical equipment. $2 is sent as a pass-through, of which $2 million goes to the Virginia State Police, and at the end of the fiscal year, $12.5 million is transferred over to the general fund. 25 cents goes to the Rescue Squad Assistance Fund, and then our trauma funds come from a separate funding stream, which has to do with licensure reinstatements. So at the end of the fiscal year last year, it was discovered that the $12.5 million, which was to be transferred back to the general funds, was not available. The agency did cover it at that time, but at that time we began a course of looking deeply into the Office of EMS to see where the shortfall had occurred. Over the course of the audit, it was found that we did have a $33.3 million overcommitment, and this was a combination of funds that were owed from previous years of unpaid bills, along with an over-budgeted projection for fiscal year 24. So what we found had happened and been occurring in the Office of EMS is that for several years, the office had been moving funds in between they had been moving the funds in between the buckets to cover the shortfalls, and they had overspending of contracts, and they had little to no VDH oversight. So we have an audit that has been initiated, is still underway. During the course of our audit, we did find suspected fraudulent activity, and this has been reported and being reviewed by the Office of the State Inspector General, along with the Virginia State Police and the Office of the U.S. Attorney. We have taken many steps to ensure along the way that we have accountability reinstituted with the Office of EMS as well as through the VDH agency. We have new leadership in place, and we have taken steps to correct spending, renegotiate our contracts, and ensure that our services are in line with the available funding that we have. Going forward, we are working with a work group of EMS leaders from across the Commonwealth that has established to advise our EMS strategy, and we also have a nationally recognized EMS consultant looking to help make sure that we craft the best EMS system for our state that is budgetarily sustainable and relevant to meet all the needs of the EMS agencies across our state and for Virginians. We are very dedicated and supported to the Office of EMS as we support the work of EMS agencies across the state. So the ask on this budget amendment is, I will just make a note that the governor did allow us to carry over $8 million from last year's general funds that were unspent and apply it to the Office of EMS to help to pay off their debts. Additionally, the request on this budget amendment would be that we retain the $12.5 million that generally is transferred back to this year in this fiscal year currently, and then also for next fiscal year, the $12.5 million. And this is in order for us to stabilize the Office of EMS as we look toward future solutions of how we better stabilize this agency for the Commonwealth.
I just want to be clear on one of the graphs earlier. 21% of your budget is the COVID funds, and they're going to run out at the end of this year. Is that correct?
As we look back at that budget item, we have approximately 21%. Some of these will run out this year, and some of them will run out over the next 2 to 3 years. There is a kind of a de-escalation of those funds across the way.
See. Okay. Thank you, ma'am. Are there any questions for Dr. Shelton? Thank you very much.
Okay.
Senator Favola's got something.
When will we actually have your plan for creating a structurally sound, fiscally sound emergency medical services program? When will that come to us?
Mr. Chairman, Senator Favola, thank you for that question. The EMS work group that we have is again working with the EMS leadership from across the state, as well as with our national consultants, so that over the course of this year, we plan to have a plan in place by the fall in order for the next legislative session to be able to have some specific actions in place to let you know how we feel that the EMS agencies can best be constructed to support EMS services, as well as our funding needs.
That's critically important. You know, I hear from EMS people almost every month about this issue, and I have for a couple of years. Yes, ma'am.
A follow-up question. So our local EMS folks are going to continue to do their responsibilities, but the state will have less of a role while this plan is being developed?
No, not less of a role. Our Mr. Chairman, Senator Favola, our role for the EMS agencies, we provide the support and guidance and infrastructure for the local EMS agencies. We do not fund them directly.
That's right.
So as we look at, we continue with our training programs and things of that nature. We weren't able to have the symposium this past year because of all that occurred, but we do have other training structures in place. So we continue to support our EMS agencies throughout. We have 11 regional councils that also provide this guidance and support.
So in summary, you're going to be providing some mandated services to the local EMS folks. They're not going to be in limbo, in other words, for the next year while you're doing your plan.
No, we're providing full services. The only thing that we are doing differently at this time is we changed the scholarship amount to come in line with the actual spending of that allocation, and we're not able to provide the grant funds this year for the rescue squad assistant funds. All other fundings will continue as prescribed, and all other work will continue as prescribed.
I just think what you just said is worth noting, which is why I asked the question.
Yes.
So thank you.
And one other note I would make, that the patient care record, which we support, will continue with its funding support as we go through this. Thank you. Another big project that we work on, of course, is opioid crisis response. So part of our opioid crisis response that we started in 2016 is helping to provide support and guidance throughout the state to respond to this emergency. In 2022, there were 2,617 drug overdose deaths, of which 2,143 were from opioids. That's approximately 6 deaths per day from opioids. In 2022, there were greater than 75% of all deaths had fentanyl involved in them. So we take the work of this task force very seriously. Part of the governor's proposed budget would allow an allocation from the Commonwealth's opioid abatement and remediation funds of $5.5 million to allow us to make sure that our naloxone distribution program, or our opioid reversal distribution plan, is funded. This helps to support the infrastructure for this plan, as well as Narcan, actual naloxone kits that we distribute to our highest risk areas and to those in need. Additionally, we have funding proposed for a wastewater surveillance project, which would be a pilot project to look at wastewater fentanyl and to see if there is any benefit going forward on a larger scale program to provide that, to help with our looking in communities to see whether or not they have an increase of opioids in their community that we can help to prescribe, giving them further naloxone and education in specific communities. When we look at this project going forward, we have an initiative in Roanoke for some increased work toward opioid overdose. So that would be one of our primary sites that we would start that. We already have a wastewater surveillance program in place that we've used during COVID that was very helpful to help us to look at communities throughout the Commonwealth to see, as we saw these numbers going up in the wastewater about 2 weeks in advance of COVID, it would help us predict areas and prepare for areas where there may be increasing COVID. So we would use these sampling sites that we have in place and then utilize them for the wastewater for the fentanyl project. We would look to see what this wastewater surveillance can show us as far as when we look at these projects. Right now, their larger projects are only at the large intake for the wastewater systems, and as we look at going further up into the communities, we can't go into communities less than 3,000 people inside. But as we look at these communities to see areas that we may be able to discover where they might be a surge, so that we can, again, blanket education and other priorities to that community to help prevent overdose deaths. Thank you, Senator. All right, as we look at our Office of, the budget requests from our Office of Family Health Services, these are requests that we have traditionally gotten through TANA for the temporary census for needy families, and as we have it has been projected that these funds have been decreasing, so the goal is to continue to support these programs through general funds. The contraceptive initiative has funding for fiscal year 25, but the request would be for fiscal year 26, and then for our Resource Mothers, which is a home visitation program for teen mothers, to begin that assistance in this next fiscal year, along with our home visitation programs, the MECHF program, which is maternal, infant, early childhood home visitation programs. And these include programs such as the Nurse Family Partnership, Parents as Teachers, and Healthy Families. Additionally, there's funding for Families Forward, which is our CHIP program, and these all help to provide the home visitation services. These visitation services have been found to be extremely helpful, and for our highest risk moms and communities where they can help to make a difference for linkage to care and making sure they get the proper medical services that they need. One of the things that our agency went through with the COVID funds is with a great increase in spending and decline, we have found that we have the need for more core functional services within our Office of Financial Management, as well as creation of a grants team. The administration has recognized the need for our stability in this area and has recommended a $1.6 million amount for our Office of Financial Management, along with the Grants Administration Office. For the Office of Financial Management, this would fund 13 positions, including a Director of Business Operations, Business Operation Managers, Fiscal Tech Accountants, Cost Accountant, internal control leads, as well as training. And for our Office of Grant Management, this would help to provide for a grants director, along with a grants program manager and grants program development specialist. And these are all to stabilize the core functions of our agency to help handle the magnitude of grants and other funding that has come through. One of the more exciting initiatives that we get to work with is the Healthcare Workforce Initiative. This initiative helps to build the workforce in healthcare throughout the Commonwealth for a variety of healthcare disciplines, specifically in the Behavioral Health Loan Repayment Program. This loan repayment program started in 2021 with funds awarded in fiscal year 2022, and it started at $1.6 million. Last year's award was for $3.1 million, and the proposal for this year is for $5 million. This is a grant program that helps to provide those who are in behavioral health specialties repayments on their loans. So this helps to decrease barriers for education and other things that would help to encourage people go into behavioral health fields. These include psychiatrists, both adult, children, and adolescent, as well as psychiatric nurse practitioners, psychiatric pharmacists, psychiatric physician's assistants, as well as licensed clinical social workers, licensed professional counselors, and licensed psychologists. The program for nursing scholarships started as back several years ago as the Mary Marshall program was initially funded from the Board of Nursing at $65,000 per year. We were grateful last year to have a $936,000 addition to this fund, as well as proposal for another $936,000 this year. And so this is for nursing programs. Specifically, it works with the nursing programs for Mary Marshall Nursing Scholarship, as well as programs for long-term care facilities, nurse educators, nurse practitioners, and nurse midwives, along with the nurse preceptor program. So we're thrilled about those opportunities. And then our newest program, I'm sorry, yes, sir?
These are all sound like phenomenal programs, but how do you market them to the students and the people? I'm just curious what your marketing plan is so to take advantage of it.
Yes. So, Mr. Chairman, Senator, thank you for that question. We have our Office of Health Equity administers this grant, and so we have worked with our nursing schools and other healthcare educational institutions across the Commonwealth to make sure they're aware of these programs. With this additional funding that we have received, we do want to make sure that everyone is very well of these programs. Our healthcare systems are very excited about these programs and well aware of them as well, but we do want to make sure that people are aware, and we're spreading the word on that. We do have a website that has further information on this, so I'd be happy to share.
Mr. Chairman, is there any way you can give us, or I would like some data to show how many per year are taking advantage of the programs? Some metrics to put with the money that we're spending there would be beneficial to me.
Yes, sir. We'd be happy to provide you with that additional information.
Yeah, I'm interested also in how many, as this program has ramped up, how many nurses we're graduating a year that stay in Virginia. And I was curious, what are the requirements for the Nursing Scholarship and Loan Repayment Program? How long do they have to stay in Virginia? How does that work?
So each of these programs has stipulations. My understanding is that most of these programs have a 2-year commitment. So once you get this funding, then you would commit to 2 years of working afterwards at the place where you've received your work in Virginia.
And Mr. Chairman, just to follow up, I guess, is there any research on if they stay longer than 2 years, or if we've ever considered making it longer than a 2-year commitment, or if that's even necessary once they're established in Virginia?
Well, Mr. Chairman and Senator, these are newer programs. They've mostly been established within the last 2 to 3 years, so we don't have a lot of longevity on them, but we'll certainly be looking at that further going forward to make sure how effective these programs are. Right now, a lot of our emphasis is even going into middle schools and high schools, various organizations across the state to really increase the interest. Right now, we've had such a decrease, especially in our nursing programs as far as enrollment, that we haven't been able to, to turn around. So we're looking at all areas of how we can further develop our workforce.
Thank you.
Mr.
Thank you, sir.
Just, I don't want to overplay this, but are you working with the Secretary of Veterans Defense Affairs with regard to We had the program to take combat medics and Navy corpsmen and move them in. I'm just trying to figure out on some of these, there's a direct nexus between the ability of our soldiers, sailors, airmen, Marines to transfer right into this. I just didn't know if those two things have synced up as well.
Mr. Chairman, Senator Reeves, thank you for that question. We have been working with Department of Health professions to see what we can do with people with these other licenses, particularly coming out of the military fields, and what their capacity or role might be to be able to transition into other programs. These are very active discussions. Thank you for that point. And the Earn to Learn program also is a little variation on this, which is new in its inception, but this takes people who are already working in the healthcare field at a lower license level, and as they're attaining a higher license, we can actually help to pay them for the work they're doing as part of their clinical hours. That way they're not having to step away from hard-earned money while they're doing their clinical hours in some of these professions, and this is a newer program just being stood up. Additional requests from our budget include funding for the Hampton Roads proton beam therapy as well as Special Olympics. And then one thing I want to note specifically in the drinking water funds, so the $2.7 million ask of general funds is actually for a $91.6 million federal match. The $210,000 there is a accounting thing carried over from last year, but what this $2.7 million does is help us attain a $91 million federal match for Office of Drinking Water, and this is for infrastructure for clean drinking water across our Commonwealth. And then we have some budget language. I'd be happy to answer any further questions.
Oh, thank you so much for your informative presentation.
Thank you all. Thank you, Mr.
Okay, Senator McPike's here, and we've got one last bill we've got to take up. Senator McPike has Senate Bill 70. As I understand it, 37 local departments of social services provide SNAP employment and training programs. This bill is aimed at getting the other 83 to provide the services. There are two different, they're varying budget estimates on what this amounts to. So what I would suggest is that we amend the bill to say that it'll have a, I guess not a cause, but just amend it to say that it'll be paid for from such funds as appropriated and is administered by the Department of Social Services. Is that all right with you?
Yeah, yes, Mr. Chairman.
Okay.
I'll second that.
Okay. Got motion to adopt the amendment. All in favor say aye.
Aye.
And then I think the bill's all right because you're just trying to get jobs training out there to people that are on benefits.
That's right, Mr. Chairman. I think you accurately described it. 40% of Virginia SNAP recipients don't have access to employment and training services, and the JLARC report on self-sustainability indicated that access does increase wages, increases the long-term policy goals I think we all want.
Okay. Do I have a motion?
Move to report.
Okay, and that's
and Senator Favola seconds.
Mr. Chairman, I just add that I hope we do supplement in the budget additional funds because I know the locals will also have concern about implementation. It is something that's worthy of making sure we figure out the right numbers to it. So, but I appreciate the creative language.
But the reason why the language I think is necessary is we have one set of fiscal impacts that says $3 million general fund a year, $4 million non-general fund. JLARC estimates $852,000 a year.
Pretty wide range, right?
A wide range, and so it's just there ought to be some flexibility with respect to how much money we can put in there. Okay, we've got a motion and a second to report. All in favor, say aye. Aye. Okay, with nothing else to do. Very creative. Very creative.